hysteroscopy to our current see and treat. There might be some overlap of what you heard this morning. However, we have different experience, so you can at least when you establish service in your unit, you know that different people are different, you can learn from different people. As you are aware, the scope of hysteroscopy service is either diagnostic or therapeutic. There is no sterilization anymore. Our milestones, we did first office hysteroscopy in 2001. It took us 10 years to progress to do first shoot on 1st of April 2011. Then VersaPoint 2011, then first my shoot 2017, behind many people. And we are the first in the country, I think. We used the only scope in July 19. It was introduced in June, just we picked it up and we got 20 scopes. Setting up of the service, I will talk about why, when, what, who, how, and I will skip through what has been covered. So we have 4 sessions a week, 3 by consultant and 1 by nurse hysteroscopist who is competent and she performs my shift. Why we do it as outpatient hysteroscopy, as has been covered, patient choice, safety, shorter journey in the hospital, cost effectiveness, all covered. The barriers for many units, lack of resources, lack of expertise, the old habits, protecting own practice, but to great extent we overcome all these barriers and we run true CNT service. Women like it, as you know, no general anesthetic, no fasting, and don't ask for the patient to fast because this is traditional advice which is wrong. Avoid hypoglycemia, dehydration, vasovagal attacks. Patient can go straight back to normal activities, but what's more important is we have increased number of women with comorbidities and obesity, so it's better to be treated as patients. One, NICE 2018 will tell you offer outpatient hysteroscopy. This is the standard. NICE will tell you also vaginoscopy should be the standard for diagnostic. And NICE will tell you you have to set up the service with the potential of moving to see and treat in physical. However, our practice slightly disagree with NICE based on the recommendation of our commissioners. So NICE offer hysteroscopy to everyone. We don't, and I agree with the commissioner, I disagree with NICE because we shouldn't do hysteroscopy to young women with heavy periods as a first-line investigation. So our commissioners in this year, the document has not been published yet. I have seen the draft and I revised it. They reviewed the evidence that NICE used to come up with the recommendation, and they found it a weak evidence. Therefore, they would use criteria for performing outpatient hysteroscopy, and we still consider hysteroscopy for hemorrhagia for women less than age of 45 as a procedure of low clinical value. I think Martin covered the tariff, so I will skip this. How we do it? The right atmosphere, confidence, competence, smooth running of the service. Relaxed, friendly atmosphere. We always advise the patient to bring a maid. We offer them tea and biscuits. And we don't use the scrubs or masks, only green aprons and sterile gloves, so we make it friendly, directly cast friendly as possible. It's important to have very clear referral criteria to your unit, so we keep evolving our criteria, otherwise it will be a dumping. People dump when they start with the patient, send it to you. So we have very, very clear criteria who will have hysteroscopy. Our unit also does go beyond the hysteroscopy, like we can do valve assistance, valve biopsies, and cauterization of cervix, superficial loop, electrode, and stuff like that. So we have other services as well. Where we have a unit that is fit for purpose and health and safety compatible. So reception area, waiting area, consultation rooms, treatment suites with integral changing cubicle, and recovery suite with recliners and beds. So this is our unit from outside when you get in. It is, we we used to have purpose designed units for 10 years nearly. We moved to a new unit which is even slightly better this year. So this is our unit. You can see the reception. We have 6 rooms, 1 for scan, 3 for gynecology clinic consultation and examination, 1 large procedure room for novasure and myosure, 1 smaller room for 1 stop EMB and colposcopy. And the 6 can be run at the same time. So this is the large room number 3, the smaller procedure room number 2, and this is the big room from inside, the consultation area, cubicle for patient to change, and the procedure. This is our recovery. As you can see, we have beds and also we have reclining chairs. We have both, depends on what the patient needs. I think this has been covered, but it is very important to select the motivated patient, the patient who are well informed by you, not by Google, because the patient can misunderstand what they read. You have to have your own patient information leaflet. The patient should be consulted in advance. From my point of view, of course, pain is an issue, but from my experience, pain is not as issue as the anxious, nervous patients. Usually the anxious and nervous patient are the problem, not the pain, because with what you have heard, Dr. Bezos and Martin talking, we have a lot of measures to reduce the pain, but an anxiety and nervousness, the patient who get worried. This is the probably difficult to manage and difficult to do. I think nobody covered this, but from my point of view, this is crucial to have sister in charge running the unit, motivated, and deal with the unit as a baby. Like we have, every time I go to a congress, Tiff asks me when I come back, is there anything new that we can introduce? That's why we are ahead of the game. Like we go to UNESCO before everyone else and so on and so forth. Anything comes new which is useful, put our feet down and we get it done. But without that leadership, unlikely to have successful C and V unit. This is crucial. This is my experience. I might not talk to you about science, but I will share with you my experience. You can leave some of it, take all of it, part of it, something. This is our team. We have more to the team. When you do the procedure, these are the personnel that you need. Hysteroscopist, whether a doctor or a nurse. You need 1 staff nurse for the equipment and 2 HCAs, 1 with vocal local and 1 for admission and recovery. And actually, our band 2s and 3s are so good. I do the procedure without the nurse, sometimes the staff nurse. This with the admin world, I have 2 HCAs with me in the week, no difference. They are well trained, they have been with us for years. You have to have good modern equipment. Don't underestimate resuscitation facilities. It is a must. Vasovagal attacks do occur. Complications are very rare, but do occur. You have to be ready. I think over the past 10 years, we had only 1 problem. It wasn't a complication, but the consultant thought the patient is bleeding after myosure, I think, more than what she should be. And we had to call the ambulance and transfer her to the other side because we were on 2 sides where the facilities are. And the patient, by the time she arrived, she was fine. This is the only hassle we had in 10 years. You have to have your own guidelines and protocols for procedure, analgesia, etc., etc. It has to be produced for your unit and your trust. Don't use generic ones. I know analgesia is covered, but our analgesia protocol is different from Telford, so I will go through quickly with you. So you know, as I said to you, different people have different ways of work. So my tips, my personal tips, be honest and tell the patient she will have some pain or discomfort. I learned that from Mr. Farouk Al-Azawi in Leicester when I started to do that. He said, from his experience, this is the best way to, best analgesia from his experience. I still carried on this since year 2000. When you tell the patient, it is not painful, they accept it now, they start listening. If you tell us more, nothing, not to worry, then with every touch you will reach out. Tell them about the cold water, tell them about the noises, etc. Distraction is the key, this has been covered. Empower your patient to tell you stop before you start. You tell the patient, you will have some pain, but if you tell me stop, I'm going to stop. So this gives them confidence that they are in control. So this is again important. Vaginoscopy is covered before. As I said, anxiety is the issue. Again. This is our analgesia protocol only. That what you use for NovaSure and for MySure, and I have something to add on MySure when I come to it. Just in our leaflet that goes to the patient to tell them about the paracetamol and ibuprofen, and we give patient gas a day. This is our standard test, right? We don't give narcotics to prevent the sickness, so we don't give anti-sickness, and to help the quick discharge as well. Most of our patients leave the unit after 10-15 minutes. Some patients after NovaSure they will come. I don't give local anesthetic, so I don't tell patient hysteroscopy under local anesthetic. We have actually presented that to our consultant at the meeting. We don't do local anesthetic. We give local anesthetic only for NovaSure. Otherwise, you give no local anesthetic if the cervix need to be dilated. If you don't have to dilate the cervix, most of them, good number of parts, probably wouldn't need to give local anesthetic. And we don't use frontal loop as well. We rely on gas. It works very well. Don't use the word numb when you give local anesthetic. When you tell the patient numb, they think it's like spinal, they wouldn't feel anything. So when you touch the knee, for example, they will jump. So be careful with what you say. And we use the same protocol as presented, 3 rhythm span, and we use intra-cervical rather than para-cervical. And you have to push the needle higher, the whole thickness of the needle, not superficial. It's not a colposcopy to do. You have to push the needle the full thickness. Right? We used to do VersaPoint when we started, before we introduced MySure in 2017, and now it has been seized. I think we got rid of the machine completely, it's not available anymore. The reason is it's very time consuming. We struggle to get the specimen out. Yes, you can cut it, then what you do, how to get it out. The patient is awake. Also, the quality of biopsy because of thermal imaging stuff. So it vanished from our unit since 2017. We don't have, again, spare time to do it for you anyway. And it is well known that balloon ablation gives inferior control to NovaSure for controlling heavy periods. This study by Bombers et al. They have done randomized controlled trials. They followed the patient for 1 year, 5 years, and 10 years. They found radiofrequency ablation was superior at year 1, superior at year 5, superior at year 5, equal at year 10. But you assume at year 10, most of women became menopausal anyway. So that's why the two technologies were equal. Also, they did randomized controlled trial for outpatient, balloon versus NovaSure, and NovaSure was superior to balloon ablation in the outpatient setting. We talked about the cavity integrity check. I will say it again because this is very, very important and reassuring. Please, I present these few slides. They represent my opinion, or my experience. Feel free to take it or to leave it. From my point of view, do not, or my suggestion, my advice, whatever you say, do not fail NovaSure. Because you can, if you select the wrong patients, you might do an audit, you find you don't get the good results because you did not select your patients well. So don't fail the technology. Use it for what it's designed to be used, or the way it is designed to be used. For example, if the patient come and tell you, my problem is heavy and very painful period, you will cure the bleeding 90%, as you have seen, but you will not cure the pain. So even in our audit, many patients who came back with assumed failed NovaSure, they are happy with the menstrual flow, but the pain component has not gone away. That's why they had hysterectomy. You understand? So they had hysterectomy, yes, they will be counted after NovaSure as the rate of hysterectomy after NovaSure is so and so. But if you exclude this patient, you will find the rate of hysterectomy after NovaSure is actually less than what is perceived, because the patient can't use pain not bleeding, but you treated the bleeding only. So be careful how to select your patient. Also, I think Sarah covered this, but this is on the college website and the college recommendation. If the cavity is more than 12 centimeters and the fibroid more than 2 centimeters, you have to think carefully. Of course, for 2 centimeters, I have done NovaSure for more than 2 centimeters, depending on where the fibroid is in the cavity. But be aware of it. If you burn part of the cavity, especially if you select a patient with very large cavity, you know that you are not going to get outcome. If it's slightly big cavity, fine. Tell the patient you will get hypomin only. You wouldn't get amenorrhea. Be aware of this study because I attended a meeting and I found people using this as an evidence for all ablation. This is Pan-Scotland study, which is published in 2011. And they include high number of patients. It's retrospective database study. They have not been through, it doesn't include recruiting patients. For 14,000 patients, right? And they came up, the hysterectomy rate after all types of ablation, first or second or third generation, is 20%. When you read the study, you will find the data was collected from 1989 to 2006. This was before the time of NovaSure is established, right? So this talk about first generation and the balloon ablation. In addition, I wrote a letter to Bijan when this paper is published because I actually peer reviewed the paper and I rejected but we published it. So I wrote a letter which is published next to it. Yeah. This study, one, they included all types of ablation together. They did not take into consideration the learning curve of people doing different techniques in different hospitals at different level of seniority. They have not excluded patients who had ablation with large cavity or fibroid or whatever. So it is mix of whatever. Yeah. So be careful when you read. Don't read the titles of the patient, but of the paper, but read what is in between. So you come up with a conclusion that it's not reliable figures. This is my personal view. I'm not sure. I have no evidence for it, but I feel I see some colleagues treat patients with northeastern, they come for NovaSure. I know NovaSure, the tissue impedance and probably the power will be adjusted to how thick is the endometrium, etc. But still, I'm not happy with it because the tradition of endometrial ablation, you thin out the endometrium. We don't need to thin out the endometrium with prostab or whatever with NovaSure, but don't thicken the endometrium. If you understand, don't do the opposite. At least leave her alone and give her hysteroscopic acid until she comes to have a NovaSure. But don't make it extra thick. Some women, when you scope them while they are on just really thick and polypoid. So why you add something that may fail the procedure? You understand? So the technology is good and very, very successful. So make it successful for your patient and yourself, if you understand what I mean. Ensure you discuss contraception, guys. Very, very important. This case report, it wasn't after NovaSure, it was after PCRE. This was the second case report in the literature. The first one published in BMJ. The second was me and Jeff Phipps in 2001 after PCRE. So placenta accreta do okay. So you need to discuss contraception. Again, some people routinely insert after ablation, whatever ablation is, insert Mirena or Levocet, whatever, as a routine. My tip, I'm against that practice for many reasons. One, many patients had failed IUS and they came to you for NovaSure, so it didn't work for them. Two, many choose NovaSure because they want to avoid hormonal side effects. Three, NovaSure alone has excellent outcome. You don't have to back it up with anything. It will work well if you select your patient. You will get till 100% result.
It's for contraception as well. There is the element of contraception.
I'm talking about routine use for everyone. But if the patient tells you this is the only contraception that I can use, fine.
Yeah.
But I'm talking about routine offer. Because some units do that. And how do you take it out after NovaSure or after, I don't know. Will it get stuck? I don't know, I have no experience. Just putting it to you. I do hysteroscopy before and after. Some people don't do hysteroscopy after. But I want to go to them and I'm sure that I check the cavity. I do it before to check for cavity pathology and to exclude false passage, and I do it after I want to see the distended cavity. I remember one patient on the day when I did outpatient NovaSure, she came to A&E with pain. Of course, A&E staff dealt with the patient as bowel perforation until otherwise is proved. Gyne registrar, bowel perforation. I wasn't on call, they called me. I said, please do nothing for this patient. The notes is not available to you because probably still the notes is still in the clinic. I did hysteroscopy after. The cavity was well distended and intact. I did not perforate the bowel. They did nothing, but the foreign did it. So this at least gives me reassurance. I said to you, cesarean section is not a contraindication. I did 5 cesarean sections before in outpatient, and I shortened the cavity. I avoid this. This is my practice. I know Martin doesn't, but as I said to you, different people are different, but this is my way. I don't do NovaSure or blind ablation for niche when the patient has big niche like that. I remember one of the midwife in the hospital came to me for NovaSure, and I thought this is not a photos. Big niche like that. I told her I wouldn't do it. So either TCRE or leave it. She decided to leave it, but I don't do a big niche like this. I do TCRE. This is our data. It has not been published yet, but presented in a congress, and 419 patients from 1st of May 11 to 31st of December 16. The follow-up period from 15 to 82 months, and the median age is 45. Most of them had outpatient, many of them had inpatient. This is since we started NovaSure, so probably the rate of inpatient now is less. We're talking about 11 to 16. So the hysterectomy rate after NovaSure in our series is 9.1%. Usually women have the hysterectomy 12 months after the NovaSure. There is no significant difference between inpatient and outpatient procedure. Overall satisfaction is 82%, but the data still in collection, not complete. And 20% of our patient, the patient in our series had cesarean section before. So 1 in 5, and we do it. There is no. About hysteroscopy after ablation, we published a case series based on our work. Then we presented data again in Vienna last year. Out of 994 postmenopausal bleeding women with endometrial thickness more than 4, we found 1.6% of them had ablation before. This is for the cohort from 2011 to 2015. I don't have data after 2015, but this is for these 5 years. So these 16 patients, 9 had thermal choice, 6 had microwave, 1 had NovaSure. And what we found is the difficulty is not for accessing the cavity, the difficulty is getting pickle sample. So you can say after ablation, you are more likely to need hysteroscopy than if the patient didn't have ablation. And the hysteroscopy in our 16 patient was successful in all. Again, you may argue that in 7 patients found it difficult to do it as an outpatient and we converted it into GA, but we managed to get a diagnosis. So in every single patient, we got a diagnosis. Probably more, not as straightforward as if we didn't have ablation, we converted many to GA, but diagnosis has been made. We performed a patient satisfaction survey, which we presented in Italy in 2016, 10 itemized questionnaire given to the patient straight after the outpatient hysteroscopy procedure, whether diagnostic or ablation. This was before the time of NovaSure. So this patient, the 100 patient, include diagnostic and NovaSure. All questions answered using visual analog scale from 0 to 10. And 93% give a score more than 8 for acceptability of the procedure, and 97 women would recommend the procedure to a friend. All women found the staff welcoming, supportive, the procedure was well explained, and the dignity was maintained. And I think this is crucial for patient satisfaction and acceptance. So if you offer good support and explanation, etc., they will manage the pain related. As I said to you, the anxiety is the key rather than the pain. 15 women described the pain during Novasure as severe, during Novasure, and disappeared immediately after. However, what we did when we did the questionnaire, we asked one of our nurses to do another questionnaire before the patient walked to the room to measure the level of anxiety. And all the patients who said Novasure was very painful, all of them scored 8 or more in an anxiety level. So the nurse assessed the anxiety level before they walked in. Again, visual analog scale, 0 to 10. So all the patients who felt the pain during that disappeared immediately after were in the anxious group. Myosure. Again, my observation is Myosure doesn't need analgesia. Not different from diagnostic in many women, especially varus women. Mine, the pain occurs when you touch the uterus, when you touch the fundus, when you touch the side, when you move the uterus from side to side. Therefore, the standard advice, if I'm sure you remember from your basic surgical skills course, when you do outpatient hysteroscopy, don't move from side to side, you move in and out. When the patient is asleep, you can move from side to side. Yes? Because touching and mobilizing the uterus is a problem. With Myosure, you don't touch the uterus at all. You don't touch the polyp and suck it out. So, varus women, unless if you need to dilate, you wouldn't feel pain. I removed the, yesterday I have done a case, 5 polyps, the patient didn't use local anesthetic or gas and like diagnostic. Not only every patient, of course, need to dilate, some patient are anxious. I'm not saying every patient, but I have done many Myosure without anything. The evidence, blind avulsion of polyps or fibroid type 1 is no longer recommended. This is the ESGE recommendation. Bear in mind, 30% of patients with TMD will have polyp or fibroid, 20% of premenopausal people will have polyp or fibroid. So you have to have technology to deal with it. This is the largest series, this is our series, largest series in the literature, published last year. And in postmenopausal bleeding women in our hospital, the rate of polyps is 16%. Right? For patients with normal background endometrium on hysteroscopy and normal papilla, and the polyp is looking normal by hysteroscopy, the rate of cancer or hyperplasia is 8%. So you have to remove all polyps or fibroids, and you have to remove them to their entirety, not by blind avulsion. The only technology that can guarantee this is Myosure. But this is again the only meta-analysis published this year, published this year, the only meta-analysis in the literature about polyp in postmenopausal bleeding women, and we found that the rate of cancer and hyperplasia in the literature, including all the studies published, is 8.9%. This is in polyps which look normal, and the endometrium look normal, and the biopsy is normal. Still you get cancer and hyperplasia and 8.9%. So you need to remove them to their entirety. Right? I wouldn't talk about the advantage of Myosure because I think this has been covered before. Just I want to show this video, and the message is select your device. How you can choose between light, reach, and excel. I got to complete this video, and it's only 2 minutes, so I will share it with you. I started with Myosure reach. HCA told me you are selecting the wrong device. But I didn't listen to them. Don't laugh. I thought it is polyp. It's found to be fibroid. That's why it was reached and struggling with it. It's calcified fibroid. There is minimal trimming here, by the way. So. No. I tried different directions, different positions. This is Excel. This is Excel.
Using Marshall with minimal analgesics, if anything. What sort of pressure, intrahepatic pressure, 70? Or? Yeah, yes. 80.
Right. In the old MySure, in the old scope, we use, if you have big patient with big bottom, the scope used to stuck at the bottom of the patient and you can't get into the cavity. However, now when we move to Omniscope, it's 2 centimeters longer, so this makes the life far easier. And the view is very beautiful. So it is video from the old normal scopes. I have not taken videos with Omniscope, but it's so beautiful. You will enjoy when you use it. I'm planning to produce some videos using it. My tips about MySure, I now stopped doing stage 2 TCRF. You know, when you have large vascular fibroid, usually it is too tiring or impossible to do it in one stage. We used to do it in 2 stages, bring the patient back 3 months later or so to remove the rest. Now, all my second phase treatment for large polyps is MySure, because by the time I did the TCRF and I removed the shell of the fibroid, it will become devascularized anyway, so they come for MySure as second phase of treatment. This is my routine now. And also MySure, I got a couple of patients that extremely high risk for general anesthetic. The decision by MDT not to take them to theater, but they have large polyp and they keep bleeding. And the patient cannot tolerate our patients. So we managed to convince the patient or support them just to remove good chunk of the polyp with MySure to ensure we are not missing cancer. So MySure helped us to get biopsy from the polyps, at least we are not dealing with cancer. So we put the patient on high dose Provera, and that's it. This is the decision management. But the MDT was concerned the polyp could be cancerous, but we excluded cancer because of MySure. I will skip this. Yeah. The problem of see and treat are the slot length. So you are prepared for diagnostic in 5-10 minutes. If you decide to treat, the next patient will be delayed. Will you finish the clinic? So this is one challenge. The second one, the patient readiness. Is she coming for an operation and treatment or come just for diagnostic? This is another issue. Need high level of experience. Not all people can do operative and diagnostic in the same time. And you need to have the right team. For NovaSure, I'm not sure about see and treat for Novasure. We have a lot of debate in different congresses. People discuss this issue. However, the Royal College insisted that we have to take endometrial biopsy before we do Novasure. I asked most of the experts in the country, Justin Clark and Good Hope, Richard Cartmel, and myself, and many people in congresses. Everyone said they have one case of cancer missed, so you have to take biopsy before Novasure. Right? So to do see and treat is may not be possible. Possible solution: send the information to patient. Tell them you will be treated if we found the polyp, or remove it at the same time. Telephone appointment with nurse specialist. We are thinking of this, but we have not implemented yet. So the nurse specialist, when we get the referral from the GP, overcome gynecology, you have heavy periods, whatever, we will bring you for procedure right away. Are you happy? Get ready, get ready, etc. We are thinking of this. This will be our next development. Hysteroscopy prior to Novasure, is that enough? I think it is enough to exclude cancer, but I'm not sure whether hysteroscopy is sensitive enough to exclude hypertension. This is the issue. Let me pause at the time. Have you used that before? Have you ever seen this? Raise your hand if you did. You saw that? You saw? Where saw this? Stove, yes. This is a stove. Do you use it? Does anyone still use it? Would you like to use it, Sarah? To keep
You
your
have to
teeth?
use it on your DRP camping trip, something like that. Your chicken goes.
If you bring it to the hospital in the kitchen, you never want. Right. We all use microwave to heat our lunch. So if you do GA hysteroscopy, you are using the stove. You are living in the concrete age. So you think you can do operative hysteroscopy and see and treat? Say yes if you can. I'm sure you do. Yes, all of us can do it. Just you need the motivation. You need. Thank you very much.